multiples of cocaine users a day. And then they suddenly just don't use it anymore because they got admitted to the hospital, and now their adrenals don't really function. So other sort of impressive things to think about. So for as much as you think that the urine tox doesn't matter, it actually matters in some of these cases, because then 24 hours later when we're trying to figure out what's happening to the patient, knowing that they are users of these different things helps to manage them down the line and understand what their pain med needs are, what their adrenal needs might be, all that sort of stuff. So the next time you roll your eyes at someone who says, "Oh my God, you admitted without the urine tox," it actually doesn't make a difference.
In the case of the cocaine users, they're saying they're doing is they respond to pressors, catecholamine pressors without the steroids?
Yeah, I mean, transiently you can use pressors, but like in the acutely traumatic patient, like the last thing you ever want to do is use pressors, right? Because you're assuming that there's a missed injury. So yeah, in the meantime you use pressors, but that doesn't really help the underlying process. It sort of band-aids the issue. So yeah, you put them on pressors while you figure out what's going on. The question is, why do I need pressors in this patient?
In the patients that you're saying that you're diagnosing cerebral, so obviously in the ED, at least catching it whatever the first 2 to 4 hours after they're injured, have you found that those patients are bouncing around between hyponatremia and hypernatremia when they're in the ICU?
No, they tend to just become really hypernatremic because we're fixing them. But then they also have severe traumatic brain injury, so you're sort of purposefully driving them up.
You don't find that there's like fluctuation. From my experience, when I was in the SICU and comparing to the MICU where you deal with like isolated SIDH, I think, I found that the SICU patients were a little bit unique in that they were just always bouncing around all over the place. And that partly I think is iatrogenic for us and how we manage them, but I was wondering if you had a different experience if you caught it earlier.
I think it's, what you're saying is exactly the point, is that we're trying to manage it, and so we're trying to give them a dose of the medication to fix it. It may not be enough of a dose or too much of a dose, so we play with the numbers a little bit more. Yeah.
And you find that's like stable?
It happens in some patients, not all the patients, but it does happen. Yeah. Different time.
And other times, remember about giving the steroids is if you have somebody who's on chronic high-dose steroids, like someone who has lupus or transplant, and they come in and now they've been stressed out because they're in trauma or they have an infection, and you have to remember to give them their stress dose of steroids or they will become hypotensive. And then you just give them 100 to 200 milligrams of hydrocortisone. It's like a miracle.
Yeah, it really is. Yeah. Absolutely. All right, any other questions, guys? All right. Oh, yeah.
Just a quick comment. So a lot of the patients with the SIDH that you need to fluid restrict, you can actually call pharmacy and have them concentrate the drugs so that you give them less fluids. And they can do this for practically any medication given through fluid.
Yeah, absolutely. That's a great point. Yeah, they'll try to work with you. If you tell them this is the problem, they will work with you as much of a pain as an acid is for them. They will work with you to switch over everything to normal saline infusions. They'll work with you to concentrate as much as they can for a lot of these things.